a bouquet of a couple of very interesting cases. Dr. Mahesh Gopalakrishnan is first. Very interesting case. Dr. Mahesh.
Thank you, Dr. Anand. I will share my screen.
Lakshman has gone on.
If I can make a very quick comment.
Yeah.
Personally, at this stage, I think based on the preclinical studies and the pathophysiology and how this laser works, I think I would like to limit the laser to within the arcades. But yes, like Dr. Ajay showed, maybe in future when we do more studies, we might come up with more further results.
Absolutely. This is not our current recommendation. This is where we are pushing the envelope, and it is fodder for further study. So this is not our recommendation right now, but this is where we push the boundaries. So yeah, Mahesh, please.
Yeah, actually, this is a case of 68-year-old man who presented with blurring of vision over 3 months with the metamorphopsia. Vision was improved to 6.9 with plus 2.5. And you can see that there is a large pigment epithelial detachment in the right eye, few pachytrusion. And this was the OCT. There is a huge serous pigment epithelial detachment with subretinal fluid on the edges, and little intraretinal edema was there also. The other eye has a pachytrusion, and this is different sections in the OCT. There are fluid all around with over the top of the PED also. So I did a multimodal imaging with ICG. Fluorescein angiogram is showing just slow filling PED, and ICG definitely shows a bunch of polyps in that notch of the PED area. And this is that notch of the PED. There was a bunch of polyps. So this was a standard PCV case with a notched PED. Had we had that photodynamic therapy, I could have. I have a similar case. I have done PDT with anti-VEGF injection, but since it is not available, I told the patient we will have either continuous injection or try this to reduce the number of injection. That is a micro subthreshold laser to reduce the injection. So this is multiple sections of angio and OCT. So the left eye was unremarkable, and this is fundus autofluorescence. So Visudine is not available, so I advised injection. Patient preferred biosimilar cost factor, and injection was given, and after 1 week, subthreshold laser was given at the area of polyps. Actually, I gave a dense 5x5 at the area of the polyp, little outside also, not covering the whole PED with 300 milliwatt power, spot size 200, grid of 5x5. And I repeated it thrice because I was not sure whether some effect will come. Anyway, after 1 month, I had a shock of my life. This was the pre on the left side and post after 1 month on the right side. So it was completely flat, and the hypermetropia also reduced. The patient was reading 6.9. He was quite happy. And I didn't give the second injection. And after 3 months, it was maintaining same. There was no recurrence at that time. And he was quite happy. He was coming very regularly for follow-up. Last week, he came, and then that small pigment epithelial detachment has started again. Probably the BVN has started growing again. So this is the last follow-up at 6 months. So is it a good option for PCV along with anti-VEGF injection? I'm not talking alone. And all of us should think that micropulse also need to be repeated sometimes. Otherwise, like anti-VEGF injection, we have no worry in repeating. So micropulse also may be repeated sometimes. So these are some of the points that I would like to. Thank you.
Very
Thank
interesting.
you.
Very interesting. And I believe on at least on this forum, everybody would agree to this. Raja, I believe, had done a couple of cases with micropulse in PCV. Raja, how was your experience in PCV?
Yeah, good to know that you remember that.
Oh, very much.
So actually, I had interesting cases where I had done micropulse laser for a patient where it was resistant to anti-VEGF. In this case, what you showed is, ranibizumab along with micropulse, and it worked. But in my case, it was about 4 or 5 years ago. where I had documented the polyp on ICG, and even after multiple anti-VEGF, he couldn't undergo PDT because of cost reasons, but the polyp was still persisting, and then I did only micropulse to that area of polyp, and then I could document with ICG the polyp had regressed. So that's when it struck me that, oh, is this something which we can substitute for PDT? In fact, I wanted to do an RCT. In fact, I still have an IRB approval, but the problem is the kind of patients that we get to do an RCT where you do a PDT versus micropulse is extremely difficult. Either you need funding, and now we don't even have verteporfin. But yes, I think in this case, it raises the question that we need to explore this further. And if it works, I mean, anybody would take it. PDT instead of, I mean, micropulse or subthreshold instead of PDT.
Yeah, very
I have
exciting
advised
case.
repeat. Yeah, I have advised repeat ICG. I will do next week, and I will try one more repeat. That's what my plan is.
I have also dabbled occasionally in micropulse in cases of PCV, especially now the PDT is not there. But I've never seen this kind of a wow effect. This is really the kind that we started noticing when we started using aflibercept. With
as far as the case is concerned, I personally feel there is no need to intervene immediately. I feel that this is a very small network that has come, and possibly I think you can observe and see. If it just remains like that, I don't think there is any need.
Yeah, actually, I am planning repeat ICG, and based on that, I will move whether to give a little more micropulses.
So Mahesh,
Mahesh,
a question: did you use a test one and reduce the power?
No, actually, I have been doing that around my machine. It works around 300. So nowadays I am not titrating. More or less, because I am getting reduced to half. I have done that repeatedly.
For clarification, you use 5% duty cycle, right?
No. This one I use 10%.
Yeah, because it wasn't written on your slide. So
yeah, 10%.
So great.